So hello, everyone. Welcome to the Clash of the Cases for the month of October. This is actually the second one that we've done. And this is kind of born out of some committees for the APDVS for the resident committee. Dr. Caputo, who's also on the line, and Dr. Emily Fan, who actually is on call today. So she's not going to be here today for this cases being presented. But we were kind of thinking that we could probably do this quarterly and invite 3 different programs to come present different types of cases, just so that the trainees at these different institutions can kind of see maybe how other institutions are performing these cases. So we're hoping to get through 3 different cases. The 3 institutions that we've invited tonight are University of Michigan, Cornell University, as well as WashU. And our first presenter will be Dr. Kai Hata from University of Michigan, and her mentors are, I think Dr. Osborne is on the line and Dr. Hinkie may be on the line, kind of as her support for some of these cases. And her first case is titled Recanalization of the SFA with Safari and Chronic Limb-Threatening Ischemia. So Dr. Hata, you can take it away.
And just a quick reminder for the audience, keep your buttons muted. And if you want to put your cameras on, it'd be great to see everybody. But if you have any questions, you can use your raise your hand feature as well. But we look forward to these cases. So, all right.
Well, let me just start by saying thank you for giving me an opportunity to present. And I hope that everybody finds this case beneficial. So I'm Kai Hata. This is a Clash of the Cases, presenting one of our endo CLTI cases from the University of Michigan. So the story, so this is a 65-year-old male with a long history of peripheral vascular disease who had been seen at another facility and had multiple bypass surgeries, revisions, etc. on his right side, who ultimately ended up getting an above knee amputation, who now presents to us following a 1-week history of a left toe wound with a little minimal amount of drainage, no fevers or chills. He lives independently with his sister, and she was very concerned about the toe and asked him to get seen. As far as relevant medical history for him, he does have a history of hypertension, diabetes, ESRD with a slightly elevated creatinine and decreased GFR. And of note, he'd had a recent MI with some coronary artery disease that was felt to be non-intervenable at the time. His past surgical history of relevance to us is his right FEMPOT bypass that eventually failed and then resulted in a right above knee amputation. This was remote and he had been healing well from this. Of note, his left limb was important for him because he used it to propel his wheelchair and also for transfers in and out of bed so that he could live independently with his sister. His medications are multiple and all appropriate for his chronic medical conditions, but of note, I'm sorry, that's supposed to say aspirin 81 milligrams and atorvastatin were on his medication list. He is a former smoker and had quit at the time of his bypasses, but he had an approximately 40-pack year history cumulatively, and he was a daily marijuana user. And as I mentioned, he did live independently with his sister. So physical exam, he was afebrile, appropriate, normal vital signs. He had a palpable left femoral pulse and a decrease to no right femoral pulse. And then he had a very monophasic DP and PT signal that were present, but very low. We got non-invasive vascular, and then a picture of his toe, as you can see. He got non-invasive vascular studies with us that were significant for really a PT and a DP that were slightly depressed, but what's really significant here is the fact that his toe pressure is only 37 and his TBI is 0.1 in the setting of what appears to be an ischemic toe. Now, there was no drainage, there was no erythema, no cellulitis, or any concern for active infection at this time, but he was evaluated by podiatry as well and felt that he had exposed bone. And then you can't appreciate it in this picture, but when you pulled his toes apart, there was some moistness. So there was a little bit of active drainage and active skin breakdown there. So looking at him, when we were talking about chronic limb-threatening ischemia, we use the Wi-Fi classification to detect their risk of amputation and the benefit of revascularization. So given his wound, and for this, I used his toe pressures rather than his ABIs because that there is a pretty stark difference between the two. But with those toe pressures, he gets a Wi-Fi it was a 1 for his wound because it was a single digit, and then his ischemia level was a 3. So he was at medium risk for amputation at 1 year. And then for the estimate likelihood of benefit, he is going to have a high benefit from revascularization. So we took him to the OR and did a diagnostic angiogram. So I think that there was a high suspicion that we would need to intervene on this. So we started with the antegrade access of the SFA. As you can see here on this picture, so this is his SFA. He has a patent profunda that you can see sort of in the back. And then here's SFA sort of peters out and eventually occludes. You can see these large corkscrew collaterals coming down to the distal SFA/AK pop here that recanalizes. This comes down, and I apologize for the pictures. The bones didn't come out super well, but here's his above knee popliteal artery. This is the knee joint about here. And so his behind the knee popliteal, all of this is very nice caliber, no significant disease. But you get to the tibials and you see his anterior tibial artery is occluded just distal to the origin here. The perineal is his dominant runoff, and his PT actually comes back distally here with this big collateral from the perineal. You can't appreciate it very well in this picture. It looks as if he does not have an intact arch, but he actually does. There was just such poor flow there during this angiogram that it wasn't very well appreciated. So here, now that we have a better idea of his anatomy, we can start talking about the GLASS classification as to how difficult, it really just predicts how difficult his revascularization is going to be, and gives you an idea of how to attack this from an endovascular standpoint. So I put him as a stage 3 for his femoral popliteal disease. And then because his PT is completely occluded and all we really have is a perineal target, I put him at a stage 4. So it puts him at a relatively high, I think it's a class 3 for the GLASS classification for endovascular revascularization or difficulty as far as that. Our main goal at this point was to get him to heal an amputation wound because his toe was going to need to be amputated regardless. And so we wanted him to be able to heal that single digit amputation. So our main target was going to be recanalization of that SFA. So he had antegrade SFA access, like I showed in the diagnostic angiogram. The attempted antegrade crossing through that, but there was encountering some resistance, and despite really weren't able to cross there. So we went distally. We ultrasounded the PT, and it just wasn't a great target. And knowing what we did of our angiogram and the fact that it had been occluded, we decided not to access the PT and instead access the perineal artery. I have some confirmatory pictures that I can show you at the end of this slide. We were able to get through the perineal, get back into true lumen for the SFA, snared it, and then did through and through access that way. He was ballooned several times, but ultimately up to 5 millimeters. And then our angiogram showed successful recanalization. There was an expected dissection, and then he was stented for about 20 centimeters. And then he had a balloon angioplasty of the PT. So once we were able to get the SFA successfully recanalized, we pulled our distal wire out, and then we're able to access we were able to select the PT very distally, and that was balloon angioplasty to 2 millimeters, just in an attempt to increase his tibial flow. So here are some of our pictures from the OR. This is just our distal access site. You can see that we've gotten intraluminal here in the perineal artery. This is the post through and through angiogram and post balloon angioplasty. You can see that there's a little bit of a dissection flap there, but we are in true lumen all the way, and that it's successfully recanalized. Here, this is after stent placement, and you can see there's much better flow through the SFA. Some of those collaterals have not vanished, but there's preferential flow through the SFA, and so those collaterals aren't as prominent. And then here, the foot shot, unfortunately, is not, I just couldn't get it at a great picture on my, oh gosh, I just couldn't get a great picture on our imaging system, but, and he had a significant amount of vasospasm because the posterior tibial balloon had gone all the way to the tarsals. but he did note increased signals and improved signals from his preoperative exam. And so we were pretty satisfied with this, and we were going to get interval ABIs to make sure that we had improved his blood flow prior to his amputation. So he was loaded with Plavix in the postoperative holding area. Post-op day 2, he had his toe amputation. As you can see, his ABIs and TBIs significantly increased. And then he was discharged to a subacute rehab on post-op day 6, mostly because we wanted him to he was going to have to relearn how to weight bear with that amputation in the short term as it healed. We saw him at 4 weeks, and his toe amputation site had healed completely and his sutures were removed. And then at his 8-week follow-up, he had repeat ABIs. His incision was completely healed. His ABI had actually increased even more to 0.89, and his TBI had gotten even better to 0.6. He was following sort of the normal postoperative surveillance schedule, but about 8 months later, he presented to the ER with a new toe wound. And this one was on his great toe, which had been present for about a month. He had definite ischemic changes, but no drainage or signs of active infection. His ABI at that time had decreased to 0.4 and his TBI was 0.2. And you can see here his duplex shows some concern for a possible SFA stent stenosis or occlusion. So we took him back to the OR, and this time we got access from the contralateral side, went up and over and shot a diagnostic angiogram. Honestly, when I shot this angiogram, I wasn't super hopeful at our ability to salvage anything, but as you can see in these pictures, his SFA is stenosed and his stent went down, and he has this collateralization around it, but he does have good outflow with a good popliteal artery and posterior tibial artery, and he still has good outflow in his foot. And so we decided to see if we could get across this occlusion again and see if we could angioplasty this in an effort to salvage it. So we were able to do that. We crossed it with an 014 wire, ballooned it to 4 millimeters, and then used a drug-coated balloon along the length of the lesion. And then additionally, we angioplasty the popliteal artery. As you can see, there's a little bit of new disease here in the behind the knee pop. And then he just had some pressure for hemostasis control of his arteriotomy. And then here are some pictures from that, videos, if they'll play. And you see we were able to successfully recanalize the SFA there. Oops, sorry. Oops, sorry. I don't know why those are on. And then here is his post shot that shows continued dominant perineal runoff. We didn't angioplasty his PT at this time, but he had a intact arch and actually good digital flow. So we felt that he'd be able to heal whatever additional amputation he needed. So podiatry was helping us at that time.
Excellent presentation so far. Good case. Can you go back to your previous slide real quick? That middle video, is that post-intervention?
Yes. This was before we angioplasty the pop though.
Oh, okay, so that's pre-intervention.
Mm-hmm.
Okay.
Well, this was post SFA intervention, pre-pop intervention. Because we balloon angioplasty the SFA stent and stenosis there. And then because we noticed that his popliteal was stenosed and we were worried about outflow causing a potential issue with the flow there and potentially causing this to go down again, we decided to angioplasty that as well.
Gotcha. But that is pre-pop intervention.
Correct.
All right, gotcha. That's all I was wondering.
So he did well for that, the rest of that postoperative stay. He needed to go back to a SAR again. We put him on Plavix and Xarelto for his postoperative anticoagulation, and his ABI had improved to 0.7. Unfortunately, he was readmitted about a month later for a recurrent GI bleed, which ended up being secondary to a sigmoid mass. And now he's getting all of that treated, and he's sort of been preoccupied with that, and we haven't seen him in clinic since then, although he is scheduled to see us within the next month. Oh, that's not what I meant to do. All right, and then I'll welcome any questions or comments at this time. Thank you.
Thank you, Dr. Hada. I agree with Dr. Caputo. Great presentation, and definitely highlights what we deal with a lot of these patients, that will get them over the hump, get them to heal their amputation, and they come right back through our doors to try to figure out how to kind of get them revascularized again. A few questions. So one, I was wondering kind of what's your practice in terms of patients that come in with toe wounds, and you're going to take them for an angio, maybe possible intervention. Do you routinely get vein mapping before to know, how aggressive am I going to be in this endovascular intervention, and kind of the decision making of preoperative evaluation of the vein? And then also wondering thoughts on, when you do the Safari technique and you recanalize a certain vessel, whether or not you guys always stent at the end, or if you just do the balloon angioplasty. I know some of my partners have gone more to just doing the recanalization and doing a little bit of voodoo, heparin, anticoagulation, dual antiplatelet, and not stenting. And then third, for the drug-eluting technology, how frequently have you guys been using that since, I guess, in more recent times?
Okay. So for the first question, I personally like to vein map everybody. This patient was already kind of dead set against a bypass because of his previous history. That being said, his vein measured at 0.01 along the length of his remaining extremity. So he really didn't have any good conduit for a distal bypass. Anyway, that being said, we maybe could have gotten away with an AK pop bypass with prosthetic for him, but given his previous history and additionally his comorbidities, while they were managed, weren't managed very. They were managed, but they weren't awesomely managed. I think his A1C was like 1.7 and he had CKD, and then they weren't really willing to intervene on his heart disease either. So all of those things combined, I think, just made him a better candidate for an endovascular procedure than an open procedure. But it is a good thought for anybody that needs CLTI. The goal is to get, inline pulsatile flow to the foot or to as distal as you can to try and heal that wound. And usually a bypass is a better option for that. But for him, just looking at the scope of things wasn't. Second, I think that the decision to stent or not is going to depend on your post. So we got that post angioplasty angiogram. It showed a pretty significant dissection along the length of the SFA. And I think that it was a good idea to stent at that time, just because it's there. I'm going to be completely frank and say that I haven't done enough of these to tell you exactly what my practice pattern is, having only seen a couple, but I think that a lot of it's going to depend on what's going on in the operating room at that time. I think if you have a limited dissection, if you really don't have any flow limitations with that or any concerns from that standpoint, it can be managed with the short-term triple therapy followed by dual antiplatelet. And then the last question was the drug-eluting balloons. So we've actually increased our use of those over, I think, the last 6 to 8 months from just compared to the year and a half I've been here. But I think because he had so our options, given the fact that he had in-stent restenosis, were going to be either to just plain angioplasty, which he was at high likelihood to fail because he'd kind of already failed that once already, reline the stents, which I'm not 100% sure what the patency for that is, but it seems like a bad idea, or with a drug-eluting balloon. And I think given those options, I think a drug-eluting balloon was going to be the way to give him the best shot at success.
Great. And we have a few questions in the chat box. So Dr. Holtzum asked, what's your protocol for perineal access hemostasis? Do you do cuff inflation versus balloon inflation?
We used balloon inflation for his case. So we had 5 minutes with a 4mm balloon.
Okay. And also Dr. Pierce, he said, had you considered a perineal bypass with a cuff or Distaflow? I know we use Distaflow a lot, and in training, I had never used the Distaflow. I think you covered a little bit about the comorbidities, but if you could talk about potential maybe in other cases where you guys use vein adjuncts and or Distaflow.
I'm going to be honest, I'm not 100% sure what Distaflow is, so I may need somebody to explain that to me. But we do a significant amount of distal bypasses. Generally, our, of course, preferred conduit is vein, and very, very rarely, especially for these tibials, will we do something like a vein patch or a different type of cuff. And then that's really a talk with the patient. Do they really want to undergo all of that? And more often than not, our patients tend to favor amputation, I think, in those specific instances. I don't actually remember how long the first case was. Sorry, I'm reading the chat now.
Perfect.
I think Dr. Pierce is,
Here, so
there we go.
I'll pipe up. So a distal flow bypass or a prosthetic bypass to a perineal vessel is less invasive than most of these endo rodeos that I've witnessed at this point. People get so fixated that the patient wants endo, and they think it's less invasive on the patient. Let me tell you, if you take a patient to the operating or the angio room, especially if you do a general anesthetic and you do one of these safaris and you're in there for 2 or 3 hours, you've completely lost the physiologic advantage of endovascular therapy. A prosthetic graft from the femoral to the perineal is honestly about as stressful as an AV access. And think about the patients you put AV access in, right? I mean, those are sick people. So I guess my point is just that for everybody on the talk, especially the young people on the talk, just because a patient doesn't have good vein doesn't mean you can't do a tibial bypass. And in fact, I actually personally, if I fail endo once on something like this, where it's the entire SFA and pop, and you're talking about using Dakota technique to get a wire to snare I will go straight to a prosthetic bypass if they don't have vein. And you'll be shocked at how many of those patients, in fact, you'll do more of that in your practice after doing it once, because it's such a much more straightforward thing than some of these endos. And it's the same concept. You're just trying to heal the foot. Yeah, it may not stay open 3, 4, 5 years, but if it stays open 8 months, 9 months, and I'll tell you, with aspirin and rivaroxaban, they stay open a lot better than they used to when we just had aspirin basically, or even Coumadin. And it's so much easier to get the patients to comply with their medication regimen. So I just throw that out there as my hair doesn't go gray, it just gives up, as an old bald surgeon. Don't give up on patients with long segment occlusion that have tibial targets just because they don't have vein. And that I know in some places that's probably heresy, but that's my take on it.
No, I think that's a good thought. I think that there are a lot of other factors that went into this specifically. Like, I think it's a big discussion to have with the patient and really talk to them about their wants and needs. And unfortunately, I think a different institution had biased him against open surgery already.
Dr. Osborne?
Yeah, no, I think I agree with Ben for the most part on all of that. I think in general, when we're talking about PAD and we're talking about what's the best thing that's going to last the longest, what's going to fail the best, I think that's what you want to really think about when you're talking about revascularization. And that a lot of times is a bypass. I will say that, I've done my fair share of distal bypasses with PTFE. We don't use BD, but I think any company's PTFE bypass is going to be fine with a vein cuff or vein patch, however you want to do it. I do agree with aspirin and some type of DOAC with that. I think low dose rivaroxaban has been shown to be pretty effective, but I do think there are cases where the patients just aren't really great candidates even for that. And I do almost all of my safaris under just under anesthetic, not under general anesthetic, just under nurse sedation. And at the VA, where the majority of my cases are, that's kind of the norm. And so it's pretty rare now that they're under general anesthetic for these cases. And so I think you can get away with a lot under a good sedation case if you planned it right, and if you plan for good antegrade access. That being said, if you ask me which would I rather do, I'd much rather do a fem distal bypass with PTFE and a vein patch. I mean, that's a faster case a lot of times, like you said, and it's a lot more fun, but it's not always what you can get. And I think this guy's vessels, I was worried about his outflow overall and the quality of his peroneal under ultrasound. We didn't go over it there, but it wasn't a very large target when we were first looking at under ultrasound. It looked a lot better there on those angios, but I think that those are all considerations you have to think about when you're thinking about what you're going to do for those patients. But I 100% agree. Endo is not the answer for the majority of patients. It can be, but it's not always the right answer or the first answer. So.
All right. Thanks, Dr. Osborne and Dr. Hata, for presenting. My last question for that case is, what is your go-to wire for your Safari endo radio?
It would be the command wire.
Okay. All right.
All right, up next we have I don't even know who we have up next. Joanna, who do we have up next?
I think Washi is next.
All right. We
Catherine
have Vipul or Catherine Holzum, depending on.
I think Dr. Holdsome is on our screen, and I think Dr. Oman is the
Okay.
faculty kind of mentor.
Yeah, so Catherine Holzum will be presenting limb preservation for failed atherectomy and trash foot. And I think the staff on this case was Vipul Ketterpol. Vipul was one of my trainees actually when I was there at Barnes-Jewish. So it seems to go full circle. I heard he's quite the wizard with wires, from what I understand. So I'm looking forward to seeing what this case is. So Catherine, the floor is yours.
All right. Thank you for the opportunity to present. So our patient, 78-year-old gentleman, peripheral arterial disease. He presented with right fourth toe gangrene to his outside cardiologist. Kind of typical comorbidities. He had already been on aspirin and Plavix and was a former smoker. So just to kind of get a look of it, his foot, clearly see got a pretty bad dry gangrenous wound, his fourth toe with, perhaps some surrounding cellulitic changes. So his cardiologist took him to the procedure suite and did an angiogram. So what they saw was occlusion of the popliteal artery with some significant calcific disease. And then more distally, you can see that he reconstitutes his posterior tibial, and he also has runoff from his perineal with a proximal AT occlusion. So, apologize. And then more distally, basically, you can see that his predominant runoff is from his PT. So the cardiologist decided to intervene with CSI orbital atherectomy with a 1.5 millimeter crown, and you can just kind of see the intervention through the popliteal. We also did the distal SFA. There was a previously placed superior stent here. And then the angiographic result through the popliteal after this orbital atherectomy was pretty decent. However, if you look more distally, you can see that his runoff doesn't quite look very good after his orbital atherectomy. The distal embolic protection was just sort of the typical CSI solution, no other distal embolic protection used. And then with the more distal angiogram, you can see that his PT, while it was a dominant runoff to the foot before, now cuts off above the ankle. So it seems like he's trashed his outflow pretty significantly. So with this, the cardiologist decides to do a few things. He balloons the tibials without any significant improvement in the angiographic result, and ultimately decides to leave a lysis catheter behind. So the patient is then admitted to the ICU postoperatively for monitoring. The lysis was continued for 24 hours. On exam, he had a Dopplerable DP and PT signal, and the lysis catheter was actually removed after 24 hours without any return for completion angiogram. For the rest of that hospital stay, he had a consultation placed to general surgery for consideration for toe amputation that was deferred, probably looking at his ABIs and toe pressures. They decided that was not the best thing to do for him at that time. He also had a bone scan performed that was consistent with osteomyelitis. So he was started on broad spectrum antibiotics and ultimately discharged with a long-term antibiotic regimen. And then these are his ABIs and toe pressures post that first intervention. You can see his toe pressure on the right is only 17. I think probably some pretty falsely elevated ABIs. So about 10 days after his discharge from this hospital stay, he presented to our ED with progressive gangrene and discoloration of this foot. You can see that he's got multiple additional lesions, not just the fourth toe lesion anymore on that same foot. And so we had considered what our intervention options were for him. amputation was discussed. However, it was decided that we would try to take him for another angio to see what further could potentially be done. So our first angiographic shots demonstrate that he has occlusion of that popliteal segment again. Important to note that there was no stent done before, only a DCB. And then we were able to successfully cross that lesion and shoot angiograms more distally to further evaluate his peripheral distal flow. So taking a look at his tibial vessels, you can see that it's fairly similar to his sort of initial angiogram in terms of having PT and perineal runoff with a proximal AT occlusion. And then looking more distally, he has the same sort of finding that was on his angiogram at the other hospital, where his PT cuts off above the ankle, his perineal kind of ends sort of mid-calf, and no great runoff from his AT. So what we attempted to do in order to treat that was upsize and put our sheath to an 8-Burton sheath and use a Rotarex device, given that it has been sort of indicated for acute thrombus as well as chronic calcific disease. However, we ran the Rotarex through this calcified segment, and unfortunately it didn't do too well in that segment. And ultimately what happened is the wire wound up shearing off of the device. You can see the wire segment here, and the wire that was through the calcified lesion is now sort of a portion of that is stuck in that lesion. And then what we could also see with the angiogram is that this also caused a traumatic pseudoaneurysm of his proximal popliteal artery. So at that point, we put up a balloon in order to sort of prevent him from bleeding from that pseudoaneurysm, and ultimately had to sort of recross the lesion through that balloon, sort of using that balloon as a catheter, and then we're able to recross, thankfully, successfully, and able to essentially open that area back up using a combination of a self-expanding stent and high pressure balloon angioplasty with a good angiographic result. So at that point, we turned our attention to sort of the more distal disease. So what is important to note is that, you know, this chronic lesion at the proximal AT sort of served as a protection to his distal tibial flow in the setting of him having this trash outflow from his prior procedure. So in shooting the picture with the proximal revascularization, you can see this, you know, AT actually lights up pretty well after revascularization. So he seems to have a blind AT segment. So the decision was made to kind of go after the AT. You know, you can see even more distally the reasonably good AT flow just by revasculating more proximally. So DP access was obtained, and basically retrograde wire access up through the AT was performed and able to cross through the lesion successfully. After balloon angioplasty, there was a flow limiting dissection. So the decision was made to advance a coronary drug-eluting stent and place that in the proximal AT. There was some more distal flow limiting dissection that was treated just by long balloon inflation. In addition to that, then we also decided to try to treat the PT runoff. So this was just treated from the antegrade approach. We went to perform balloon angioplasty and ultimately were able to kind of wire through the entire pedal loop. And ultimately the end result was he had essentially pretty decent 2-vessel runoff. He has a lesion in his PT into the foot that, you know, was seeming to be chronic, and we were not able to kind of improve that with multiple attempts at inflation. So after these interventions, this gentleman had great ABIs and importantly, great toe pressures as well. His toe pressure was 107. So he ultimately underwent TMA with our podiatrist. And after about a year of follow-up, his TMA is well healed and he is doing well and working to get a better prosthesis for his shoe now at this point. So overall, a good result from a fairly complicated patient. All right, that's all I have. Thank you.
Dr. Holtzum, I may have missed it. What antiplatelet and anticoagulation regimen did you do?
So he was on dual antiplatelet therapy on discharge with aspirin Plavix, and he remains on that today.
Where'd the sheared wire go?
So that just got trapped behind a stent, basically.
What kind of lessons have we learned in this case about using atherectomy?
Well, I mean, I think that, using atherectomy without a distal protection device, in the setting of, CSI orbital atherectomy, you could still use distal embolic protection with using the Viper wire with the 017 end and a NAV6 basket, which I think, in the setting of having poor outflow might be worth pursuing if you're going to be doing a significant atherectomy. Also, the Rotarex, I would say, was not the best device to be using in the setting of a significantly calcified lesion. I would probably not choose it again for that situation.
Yeah, I think they discourage use of Rotarex in calcified lesions. They say if you really want to use atherectomy in calcified lesions, you can use directional atherectomy with the Silver Hawk or Turbo Hawk or orbital with CSI. But I don't think the Rotarex is really designed for that. But good case, good save.
So I actually learned a lot in this case. First of all, use of atherectomy, like Peter was mentioning, even CSI, they recommend a lot of times not using distal embolic protection, which I think is a bad idea for any atherectomy device. So for CSI, the cardiologist who, he was kind of trying to modify this heavily calcified pop lesion, which was a tough CTO to begin with. I don't think that would have been my first choice to treat that lesion in an endo fashion, but if something like that has to be considered, use of NAV6 or something like that would be appropriate. Like Dr. Conley mentioned, Rotarex, this was our first Rotarex case, which when it had just hit the market, and the thought was to use it for the pop lesion that was occluded about 3 weeks prior to our intervention, thinking that the lesion was treated with a DCB and it would have some subacute clot based on the duplex that we saw. Clearly we were wrong. This was just a heavily calcified lesion that was undertreated at the initial intervention. So Rotarex has a very strong suction, and when you're using it in native vessels, you have to be very, very careful that it will literally just suck the vessel wall in and shear it. So I think it's a very strong device for subacute and chronic stent thrombosis, but not a great device for native vessels, especially calcium. So a lot of lessons to be learned in terms of atherectomy and limb salvage from an endo standpoint in this case. But based on our previous discussion, this case would have been simpler if somebody would have done a FEMPT bypass with cough or done a good endo intervention in the first place.
There was a question from if there was any dissection from the prior angioplasty, it probably got sucked into the Rotarex.
So whenever you're having used Rotarex a few more times since then, having learned these lessons, whenever you're using Rotarex in a native vessel, you have to move in and out pretty quickly. And I think I had no experience using it like that at the very beginning, and neither did the reps who showed up for the case. So if you let it sit like any other atherectomy device, so for example, if you're using a CSI or you're using a Jetstream, which are orbital and rotational atherectomy devices, you need to let the devices work at the site of the occlusion for some time for it to modify the lesion enough before you start pushing. If you do the same thing with the Rotarex, that will always cause damage to the intima of the vessel, regardless of whether there's a dissection flap or not.
Question from Dr. Hankey from University of Michigan. Impressed a TMA healed without pulsatile flow to the foot. Tips on good TMA technique. Now, this was a right TMA, correct?
Yes, it was a right TMA.
So what were your toe pressures at that point?
100.
100.
He had a palpable DP.
So I'm usually pretty good with anything over 40 for toe pressure. I think Dr. Henke brings up some good things with like techniques for a good TMA. Everyone just thinks you just take the forefoot off with the intern, have fun. But I think there are some things you can do to make that TMA heal. And I do a purely sharp technique with a TMA. I don't know what anyone else does. And if I'm ever really that concerned, I'll delay close it to see how it's healing. I sometimes think early sutures leads to necrosis potentially, but what do you guys do?
Most of the time our podiatrist does our TMAs at this point, honestly.
Mr. Card is thank God he's not online right now. He'd be eating you for dinner if you with that comment. But
So Frank, changed since you left. So we have a limb preservation team now that works together. Yeah.
I'd agree. I think we can do a great TMA, and probably Frank and I have more experience than a lot of people on here. However, I think that if you have a multidisciplinary team with a podiatrist, I think it's that's what they do, and I think they
you gotta have buy-in though with the podiatrist though. You gotta have a good podiatrist, right? There's podiatrists.
Oh yeah. You can have a crummy one for sure, but if you have a good surgical podiatry team and you work with them really closely, I think it's critical for a lot of these really complex patients, because then you can turn your attention to something else like your aortic work. Instead of whittling on these feet. Also, I've found that the podiatrists are much more aggressive committing to TMAs. Like on that foot, I'd probably just take that fourth toe off and see if it heals. As opposed to, they'll be much more aggressive, at least saying, listen, in terms of functionality, getting this foot healed, a TMA is what you need. Whereas, back when I was doing a lot of my own foot care, and I still do a lot of it, but I would take that fourth toe off, see how it heals, and then kind of follow them down the line, and then they end up having worse function, or the toes become all crooked, and then you've offset some tendon in the foot, and then they've got they're putting pressure on something else. Anyway, I don't know. I think it helps to it's like a divide and conquer type of thing. And I think we're much more efficient that way and effective with the kind of all these institutions and groups that are embracing this multidisciplinary approach. I think it's here to stay.
I agree. We have 2 podiatrists within our division at UAB, and it's helped significantly with a lot of these complex diabetic and end-stage renal disease patients. I think they also are a lot more willing to leave things open, and I think they're also more aggressive with offloading than what I always did in training. And now as an attending, they will try to get them those scooters and really train them to be off their foot, which I think makes a difference. Well, thank you, Dr. Holdsome, for presenting that case. And I think we're going to be moving on to the next case. So the next case is from Cornell University, and it's they're presenting a case called or titled aortic endarterectomy, and it'll be Dr. Nag and Dr. Connolly, and Dr. Morrissey may be on the line also.
I can appreciate you turning a PVD talk into an aortic case. So you get extra points for that, Dr. Nag. So that's kind of very nice.
So we'll be shifting gears a little bit, but this case is also actually a limb salvage case because this lady had a wound on her leg. So she's a 75-year-old woman who presented actually initially primarily with buttock and thigh claudication. Her risk factors include hypertension, hyperlipidemia, and a long history of smoking, but otherwise her medical history is limited. She did not have any significant cardiopulmonary comorbidities when she presented, and she's independent and very functional. Her only medications at the time were atorvastatin and amlodipine. And she, I'm sorry, this is a typo. She had a normal creatinine at the time. But she first presented to an outside facility where she had ABIs and duplex that showed reduced flow to bilateral legs, worse on the right side, and then underwent a CTA that you can see here. Essentially shows multi-level disease, but the most impressive things were a heavily calcified plaque just inferior to the renal arteries, and then area of patent aorta, followed by another calcified plaque just above the bifurcation. She had some eccentric lesions in the iliac arteries, but those were generally not critically stenosed. And then she had SFA disease on the right side as well.
I would say she has an SFA occlusion on that right side, right?
Yes.
All right.
So she presented to us in February, again, with symptoms of primarily claudication. She underwent an angiogram at the time with the thought of attempting to recanalize her aortoiliac segment, which was unsuccessful. She had just very heavily calcified eccentric plaque noted at the time.
What was going to be the plan if you did recanalize the aortoiliac segment and you still had that disease proximally in the mesenteric segment? Were you going to do that too?
No, so the plan was not to address the mesenteric segment at all. As far as we could tell, that was not symptomatic in any way. She had normal renal function. She had no symptoms of.
Oh yeah, but I mean, you might have a pressure gradient there, though, right? I mean, that thing looks like a piece of cauliflower hanging out in the aorta, right by the renal. So I mean, you're gonna just right because you do need inflow too. So.
Yeah, no, I think that definitely played into our ultimate decision making.
I mean, it looks like you crossed it because you got across. You have femoral access.
Like you across both lesions, you're through it. I mean, what couldn't you get through?
Question of getting through, it was a question of whether it was an appropriate treatment, and given the shape and the eccentricity of the plaque and the location close to the renals, I decided it wasn't appropriate for endo treatment.
Yeah, that makes sense.
So after this aortogram, she came back a couple months later and actually had a wound on the right leg at that point, and still had significant limitations with walking as well. So the discussion was for an open operation, including aortic endarterectomy versus aortobiliac or aortobifemoral bypass. So our approach to this was through a midline laparotomy, transperitoneal approach. We isolated the aorta, bilateral common iliac arteries, as well as bilateral renal arteries by mobilizing the renal vein. And then once we were in the operating room, we were able to sort of appreciate just how focal and calcified these lesions were. And they really didn't extend into the iliacs significantly at all. And the primary goal, as you said, Dr. Caputo, of treating sort of the infrarenal lesion was to provide better inflow. So we were able to treat both of them through a longitudinal arteriotomy and endarterectomy, which left a widely patent aorta, and then that was primarily repaired with felt plagets. This is an intraoperative picture showing the proximal clamp site, which was again above the left renal and below the right renal. And then in terms of the proximal distal clamp, so distally clamped on the common iliac, which again was not significantly diseased. And then proximally, in performing the endarterectomy, we're able to get basically to the origin of the left renal artery, pull out all that bulky calcified plaque, and then started the repair, and then moved the clamp down below the renals to finish the rest of the repair. This is some of the plaque that came out. Just impressive. I should have included a ruler for scale, but it's fairly large. She ultimately did well, so she had an uneventful course. She did have sort of some slow motility and took a while to be fully mobilized with physical therapy. Her right leg wound we treated with the local wound care and enzymatic debridement, and she was ultimately discharged to subacute rehab on post-op day 8, and has since healed her wound and continued to recover. But again, a lot of the decision making here was in terms of the durability of the intervention. And in this case, this should be a fairly durable treatment for her in an otherwise functional, relatively healthy 75-year-old woman. All right, happy to take any questions.
Dr. Nag, that was a great case. Dr. Hinkie from Michigan had a question. How do you ensure your aorta isn't too thin? And do these have long-term risk of aneurysmal degeneration? And I guess to add on to that, was there any consideration just to do an aortic tube graft?
Yeah, so this is the only aortic endarterectomy that I've participated in, so I don't have large experience. Based on the literature, I think that the patency is reported to be good. I think that definitely thinning out their aorta too much is a consideration, which is why we pledgeted essentially the entire repair.
When you say pledgeted, did interrupted?
No, just 2 long felt strips.
Okay.
Yeah.
And what were the post-op ABIs?
She had a video visit, but I haven't seen post-op ABIs documented. She's scheduled to come back this month.
So yeah, I do recall that before she was sent to rehab, she actually she had triphasic signals on the floor. So this ulcer on her right leg had become gangrenous. I actually was hesitant to treat her just for the claudication, just because of how much this operation is. And I think a lot of times patients, even though you tell them how extensive a procedure it's going to be, they're not always prepared for it. But the wound went from being gangrenous and quite large to having now completely healed. And that was really the main thing that pushed us to do this. I haven't done a ton of endarterectomies either. I did this with one of my partners that joined us as well. And I think the concern was that about the thinness of the aorta, but with pledgets on either side, longitudinal, it held up really well and had a really nice result. And we avoided having to do the tube graft, which would have been longer and could have also, been, more of a risk given her infection at the time with prosthetic.
Dr. Holtzum had another question. How did you address the right infrainguinal disease and any plans for the iliac disease noted on the CT? I think there's some calcific plaque in the left common on the original CT.
Yeah, that's a great question. So I think, so we definitely discussed how to address the SFA occlusion, particularly with the wound on that side. Ultimately, based on our result, we felt that the inflow had changed significantly. And she was also reluctant to undergo any further interventions at the time. So we elected to, be aggressive about wound care and follow her closely. And she's done well with that. But that was definitely part of our conversations initially, is whether to treat the SFA occlusion at, either at the same operation or soon afterwards. I think the iliac disease was not as hemodynamically significant as it appeared in the CT, based on her pulse exam and our initial result.
And I do agree with Dr. Henke's comments. You should subvert these long terms, right? So anytime you do an endarterectomy of the aorta, there's potential for annual degeneration. I forget the exact percentage. You look at some of the largest series of that. But I mean, I think that's a great case, and you did it for the right reasons. And it's nice to have native tissue in there for sure. So I agree with all that. But anyway, there was a question a couple of paragraphs ago about how do I become a presenter? So the way this is kind of started was like over a couple of beers with me, Danielle, and Emily, and it kind of like grew on to something that we enjoy doing, especially after the tone of the pandemic. It got some of the institutions together. I think if you are interested in having your program present, you can email me or Danielle. I can put my email up here somehow. You would think after 2 years of Zoom, I'd actually figure out how to do this, but .org. And we can definitely get you on the docket. I think we're starting to realize how we kind of like it, but I just want to say those are great presentations. It's nice to see some friendly faces around. Danielle, you have anything to add?
No, I think it's been really our second session, and I think it's always nice to kind of hear tips and tricks by other faculty and other institutions, other trainees, how they're doing it. So we want to keep going with this. So if anyone has any suggestions, please email us. I think our first session was more aortic based. This one was PAD based. So maybe the next one can be, renal or visceral, kind of mesenteric based. And hopefully everyone enjoyed it.
All right.
Yeah, great stuff, guys.
Yep.
All right. So with that, if you guys have any suggestions or things to think about, just email us. Otherwise, everyone have a great night.
All right. Good night, guys.
Good night, everybody. Thanks to everybody.
Thank you.